first of all, thank you, Lyco and Arvind Eye Hospital for giving me this or Orbis this opportunity to talk about our experience around ensuring true effectiveness through one of our program called Reach. And it is a privilege to be here with all my fellow colleagues and then participants because this is a very auspicious month as Dr. V celebration plus October Summit always in this particular month we celebrate. So I'm very happy to be part of this. So I'd like to share this REACH program. Probably I don't want to talk about school eye health per se because everyone knows all of or engaged in the program management thing. But I think one sentence I'd like to talk about in this particular slide that how a pair of spectacles is so important to change somebody's life. If the timely intervention is not done or timely a pair of spectacles not on the face of a kid with refractive error, the life get totally changed altogether, either this side or other side of it. The reach, I think we have been doing school eye health program for a long time. Everyone is engaged in school eye health program for decades. What is that need for us to think about making little changes in the existing program and how the school screening programs are designed and implemented. So there, I think this reach came in, and then we thought of creating a little bit of change and then bringing more outcome-based program or outcome-focused program instead of having an output-focused program, because Orbis also has been supporting our school eye health program for a long time. And in 2016, we realized that no, can we also make a little bit of changes into the way we are implementing it. There are main two regions we put in there because before conceptualizing rates. One was that no, there are evidence that showed, and less than 30% of kids they are compliant to spectacle wear after given spectacle to them, which is a very big important point for Orbis and then all our people who are implementing programs, because 70% of those investment is going in vain because only 30% less than 30% of kids are wearing spectacles, where all of them they need spectacles. So that's why we thought that why not thinking of a program, and then same program can be a little tweak and then see that now if we can make it a outcome focused program. And we laid down a very comprehensive process. The second half of the slide, if you look at that is what the process that we put in. We also included one of the key components, annual going back to the same school for screening new students and the children who are identified for secondary evaluation last year, so that every time you have this opportunity to have annual eye screening done, and then if anyone has anything, they can be referred to the vision center or being treated in the school. So the second point was, one is this less than 30% wearing spectacles. The second one is there is no standardized service delivery that improves quality or design for service delivery that improves the quality of refractive error among school going kids. So these are the two things we thought that we'll just, one is standardization, other one is can we do some program design which is going to impact more and we improve compliance to spectacle wear. So that's how the REACH design is developed, and this REACH model was designed basically with three distinct phases: prepare, deliver, and consolidate. And every phase has a standard process to follow, which was developed in consultation with the implementing partners, because it was not developed by Orbis. We sat together several times and then developed this particular design based on the need for school eye health program in various locations. So that this three distinct phases are supported by the well-defined features called well-defined process and standardized guideline, awareness, and then demand generation, and the entire program was implemented with a technology-based solution called ReachSoft. And then last one, since we are standardizing all the processes across all the locations, and you're collecting all the data through data management system, so you are a good position to include also multi-centric research component within the program design. So that's how this was designed that way. And what we saw that no, the partner engagement was the key for the effectiveness of our reach program. How that is like the partner involvement, we did it in every stage. So these are the 5 stages that I'd like to. I'm not going to explain each of the stages, but I'd like to give a little bit of example around. It was indeed a participatory program management experience, right from the baseline assessment to feeding back to the program design for future improvement through continued consultation with the implementing partners. I think each partner institutions also not less than 30% cost was contributed by each of the participatory partners in implementing this program. That shows that how deeply the partners are engaged in implementing this particular REACH program. So I'd like to give one example to run it through so that how the partners are engaged in the every stage, just to give them give you a little idea around that. So this baseline also, we did a KP study before institution, starting the program, KP meaning knowledge, attitude, and practice study. This was done by one agency called Ipsos, but it was implemented through all the 6 implementing partners, all these locations. I think 8 districts we did in covering 5 states. All these 6 partners has conducted this KP study. One of the many key findings is like children, they don't teach each other because they're wearing glasses, but they teach each other because of the shape and color of the frames. So that was one of the many findings. I'd like to thread that particular findings and how partners are engaged in the various stages. I'd like to mention. So the baseline information also collected in collaboration with partners. The second one is the program design. This information was used by each of the implementing partner to create a provision of spectacle library within the program design, so that right to choose can be for the children can be ensured to the program. That is one. So that is every implementing partner was engaged into it in defining that particular design. The second comes to strategy development. The strategy development was based on this particular information. A strategy was also developed to create a pressure group around the child in the school, who are provided with spectacles. When choosing a pair of spectacle, the best friend accompanied the child while helping him or her choose the right color and shape. So that strategy was integrated into the model, and then that was actually through a lot of consultation. We did that with all the implementing partners, and the the implementation of the second one, if you look at that, no, this also how the implementing partner also learned from each other into the process during the implementation. As one of the partner also created a vision ambassador peer group in few schools, and then that vision ambassador peer group is basically replicated or adopted in all the other 5 partners. So it is more of a kind of cross learning also happening during the implementation phase. The implementation, the other point is around the review and recommendation, the last part. The review and recommendation based on the implementation experience by all 6 partners also have created opportunity not only for Orbis, but also for the implementing 6 partners to improve the REACH program step by step. It was first one was REACH phase or REACH 1.0, and then we also eventually improving based on the findings and recommendations in the REACH 1 to reshape the model to reach 2, and then from reach 2 to reach 3. So that is, we call it a evolution of reach, continuously evolving this program while we are implementing. The first one was reach 1.0. Salient feature was basically it is school based, or school as the hub of all the activities, and then referral is made to the base hospital for further intervention. Choice of spectacles were provided within the program as a kind of strategy, and compliance was done at the 3 months of spectacle delivery by the project team. And then annual follow visit, every year they go back to the same school and do screening and provide care what is needed for the new kids. But interestingly, when we reached one was ended, we did the analysis, and then we also got together all the implementing partners and then draw the various analysis, because it was easy for us to do the analysis because all the data was in it was software based or data management system. Through data management system we did it. So the analysis shows that now, although we plan for 13 means all the schools need to go, we go back annually, but only 13% school we could do the annual follow-up visits during the project. And then challenging the post-project continuity also due to little high operational costs, because it was on a project mode we implemented. 68% spectacle compliance rate, even if we delivered the glasses into the school. 36% referral uptake for children who were referred to the base hospital for further treatment and follow-up. This is, I'm talking about the entire database the REACH has generated in the REACH 1. Interesting, that other point was time of the tertiary level facility investing time in the primary eye care, which is one of the key point, and then a recommendation, finding out of the REACH 1. When we analyze the non-compliant group of children, and then there are two largest causes. One largest cause of non-compliance still, even if we given them a choice, still the largest cause was dislike spectacles. And then second largest cause was broken or lost spectacles. So these are the 2 points also actually given us, so all our implementing partners and Orbis wanted to think about and see that now if anything can be added or tweaked in the current successful REACH program, because this REACH 1 was a very successful program standalone, because 5 million kids, it was all Sightsavers also was part of this particular program, apart from other 6 centers. So it was successfully implemented. But I think from a tweaking point of view, last 2 points, if you look at, if we need to really think of continued provision of spectacles to the kids if they need it. If it is not made within the program design, I think probably it is going to be difficult for get access to them on a continuous basis. So based on these findings, the REACH 2 was developed and then implemented in 4 partners. So basically, Vision Center was, instead of school, Vision Center was hub, or Vision Center Primary Eye Care Center was a hub for all the activities providing continued access. Only primary screening done in the school, referral to the Vision Centers, and they have better choice of spectacles because Vision Center has the capacity of having lot more different frames and then colors and then shapes. So they can choose out of them very easily. And then structured follow-up mechanism also put in place from, say, Vision Center following up to the school and then parents to bring them. The most important point here is the parental contact. When we ask them to bring the child to the Vision Center, it is always accompanied by parents. And then parental contact is strongly established through the REACH 2, because they come to Vision Center and then they are understood that the importance of the pair of spectacles and why the child is need to continue wear the spectacles. So those shows basically we did the analysis of this REACH 2 data. I'd like to show few of the significant improvement from both the data set that we have compared. So if you look at the school visits for annual follow-up, in the REACH phase 1, it was 13%. That has improved to 56%. because it is vision center based, and then they can reach out to their limited schools within the catchment. Referral compliance improved from 36% to 49%. Spectacle acceptance, which was 68% to 84%, when we delivered those spectacles and the refraction, examination was done in the vision center. And then spectacle compliance, which is one of the key things that made us think of a tweaking of the existing school eye health program, that has gone up from 66% to 85%. These two, reach one and reach two, I'd like to also mention this. Spectacle compliance was, when we started this, it was less than 30%. We have improved to 66% through reach phase one, and then it has gone up by to 85%. So that's how it is. The trajectory is going on only because we keep thinking on how this existing program can be improved further, so that outcome, it is the phase one, if you look at, or reach one, if you look at, we put it as output to outcome focus program we successfully made. The other one is from isolated program as a kind of refractive or school screening program as an isolation. This phase two or reach two has helped us to integrate into the existing outreach program, because vision center is existing outreach, there you integrating reach there, so that it is more towards integration that was done in the phase two. But still, there is a challenge, because 56% is not enough for school visit. 100% we should be able to go back and then go to the school and then do screening for, on an annual basis. Referral compliance also, if you look at that, it is 49%. That is not that. We did a very successful recently operational research, which actually shown this 49% gone up to 72% of referral compliance, by making only 3 calls and then content rationalize calling to the parents and then schools. So then reach 3 came in. This reach 3, basically we haven't implemented. This design is tweaked currently, and then in future reach is going to be reach 3. So this is like vision center to adopt schools. Earlier, under vision center, without letting the vision center know that what the capacity is, we add the schools there. But now, with considering the capacity of the vision center, how many in the catchment, how many schools they are going to cover, and that coverage, it is not only going to be the coverage, it is but adoption of those schools that needs to be put in place. The improved guidelines, advice and referred, there are a little bit of tweak in the existing guidelines we put in. We also add in reach 3 a quality assurance module for primary screening, secondary evaluation, that means refractions, and then spectacle dispensing. That is added to improve quality further. And then spectacle compliance, teachers and vision ambassador in the reach 3 is going to be engaged in for spectacle compliance. So local resource mobilization to support spectacles going forward. So we put it like the reach 3 is going to be sustainability to scale up. So this is how this reach 1, reach 2, and reach 3, based on the partners' input and then our experiences, we put in continuously tweaking the way we are implementing it in order to improve outcome of all the interventions that we have under reach. Quickly, interestingly, the partners that we talk about, there are 2. So the reach phase 1 data being analyzed, and then from the database, already 2 papers got published, one in BZO and other one is Clinical Optometry Journal. And 4 others are under development. I'd like to just mention that now all these papers that he has seen and then going to be seen out of reach is going to be led by each of the implementing partners. Orbis is going to be a supporting partner, but all these publications are led by the implementing partners. Then for outcome focus, quickly, I just wanted to mention that now, since we talked about the outcomes, and then it's a deliberate effort to focus on outcomes. So the 5 areas that we continuously follow and then continuously tracking, that is screening efficiency, that is currently it is 70%. The referral compliance, that is also tracked very diligently for all the reach programs. That is currently 49%. I told you that recently we did something and it has improved to 72%. That particular tweaking also going to be putting in into the a new REACH program. Spectacle uptake, currently acceptance rate is 84%, and spectacle compliance is nearly 85%, which is good. And then annual follow-up school coverage, that in the next 56%, that also need to be improved in the REACH 3. So this is basically through screening efficiency, spectacle compliance, annual follow-up, and then last one where efforts to more integrated approach, low-cost tech-driven processes with local level of resource mobilization. Now all our partners, including national level hospitals, we put together a proposal um, for conducting a research which is going to look at the impact on learning outcomes, a pair of spectacles on the children's educational um, performance or academic performance, or impact on the learning outcome, which is going to be a new information for India, because India, we do not have that particular information currently. This is all we say that now a pair of spectacles is going to improve their academic performance, but it is not documented or evidence generated within India. China and Sierra Leone and all these places, they have done it. I think similar way, all are implementing partners for REACH, and then national partners like RP Center, LV Prasad, Shankar Netralaya, Arvind, a part of this particular proposal. So we're submitting it, though we are together, we are going to also generate this evidence for India, so that I think we have a reference point that now by giving a pair of spectacles, the child is going to perform academically better. So that's what I wanted to share. This is the Eyes on Future. Thank you so much for your time.